Hi, everyone. Like Kate said, my name's Andrew Lee. I'm a general otolaryngologist or ENT doctor over in Rockville. Thank you for having me today. Happy New Year to everybody. So today, the goal of this conversation or this talk is really to kind of go over common general ENT complaints that I see in my everyday practice. I see both adults and pediatric patients, so kids as well. The primary focus probably of this talk is more along the adults, but if there's questions about adults or kids, please just let me know.
Yeah.
We'll kind of go over common causes for the conditions, as well as potential management options, whether that be sort of home remedies, medications, and or when to sort of seek further care. I have no disclosures.
所以我可以稍微翻译一下，李医生是在 Rockville 执业，然后他看成年人的耳鼻喉科和这个儿童的耳鼻喉科。那我们今天呢，就是讲一下耳鼻喉科的一些普遍的状况。OK， 好 ，We are good to go.
Okay, so thank you. So for the objectives of this conversation are really, again, to review common ENT related conditions, the different management options that are available, as well as red flags. We'll go through, again, the most common ones that I usually see, including tinnitus and hearing loss, ear pain, nasal congestion, postnasal drip and runny nose, the triad of cough, sore throat, and throat clearing, and then kind of end it with snoring and sleep issues. So in terms of the actual talk itself, so we'll start with tinnitus and hearing loss. When we talk about tinnitus and hearing loss, so what is tinnitus? Tinnitus is really, the definition of tinnitus is a perception of sound in the absence of external acoustic stimulus. So basically it's fancy words for you're hearing a noise that's not actually being claimed in the outer world, but it's something that you hear just sort of internally. A lot of times patients will describe it as ringing, buzzing, hissing, roaring. It can be any type of sound. But regardless, it's a sound that other people in the environment won't hear. It's thought to impact about 10 to 25% of adults. And a lot of times it actually increases with age, in the sense that more and more patients will notice it or hear it as they get older. When I talk to patients about tinnitus itself, I explain to them that it's typically associated with some type of hearing loss. And it can be most commonly age-related changes, but it can be any type of hearing loss. It can be hearing loss from trauma. It can be hearing loss from noise-induced hearing loss. It can be wax in the ear, all different types of sources. But at some point, the body or the brain, when it's not getting the sound that it expects at a certain level, it can then produce that stimulus. So when we talk about hearing loss and kind of how it connects with the ringing or the buzzing, there's really two broad categories of hearing loss that we discuss. So there's something called sensory neural hearing loss, which is really what we call nerve-related hearing loss. And that has to do with hearing loss that's associated with the cochlea, which is our organ of hearing, or the nerve fibers that transmit the sound from the cochlea to the brain. And then there's conductive hearing loss. So conductive hearing loss has to do with, again, the sound just not being able to get in, or it's being blocked in some form or fashion from getting to the cochlea. And that can involve the middle ear space, which is pointed to through that arrow, or the space behind the eardrum. It can also involve anything in the outer ear canal. So if something, again, like wax, or if there's a foreign body or something just causing blockage of the ear, not allowing the sound to get in. And then again, sometimes to do with what we call the eustachian tube. So the eustachian tube being the tube that connects the space behind the eardrum to the back of the nose, and allows you to think of like when you're flying, to pop your ear. If that's not working properly, that can also cause blockage or pressure in the ear. So again, just kind of getting back to the different types of hearing loss. So again, sensory neural hearing loss affects the cochlea, which is this little, think of it looking like a shell in a sense. And that is the main organ of hearing. Again, the nerve fibers that are blocking that can also result in the nerve-related hearing loss. So in terms of hearing loss in general, we'll kind of go over some of the different impacts of hearing loss in the sense of sensory neural hearing loss or conductive. The common causes of sensory neural hearing loss include age-related changes in hearing loss. That's probably the most predominant and actually the one that leads to most of the tinnitus or ringing in the ear. There can also be noise damage or noise-induced hearing loss. Less common, but also something that we talk about can be certain drug effects on hearing, sometimes by impacting the way the nerves process or work because of the way the drug interacts. That can also lead to nerve-related hearing loss. Other less common include brain tumors and or trauma to the ear. When we talk about conductive hearing loss, which is actually probably the most common type of hearing loss we see in kids, fluid tends to be the most common finding, fluid in the space behind the eardrum. Again, that fluid can lead to blockage of the ear, blockage of the ability for the sound to actually get in. Allergies, ruptured eardrums, wax, all those can also impact the ability for sound to get in. And then there's also mixed issues that can affect the hearing. So mixed hearing loss being a combination of both nerve-related hearing loss on top of conductive hearing loss. And that can be the result of, again, most commonly probably viral and or bacterial infections in the ear and also potentially genetic disorders. So when patients come in complaining of tinnitus, I always tell patients the very first thing that we want to figure out is there something affecting the hearing? And really the initial step is to get a hearing test, because the hearing test really teases out what type of hearing loss might be present and can give us a better clue of what's actually impacting or causing the tinnitus or the ringing. In general, I tell patients treatment is very difficult for tinnitus. A lot of our goals when we talk about the ringing or buzzing are really actually tailored towards finding coping strategies to try to prevent, again, it impacting the quality of life of the patient. The most common thing that I tell patients to do, because tinnitus itself most commonly is worse when things are really, really quiet. So think of like when patients are going to sleep, or if you're in an environment where there's no other noise or sound in the environment. The brain has nothing else to focus on. So a lot of times that's usually when it produces its own internal stimulus, and that's what people hear as a much louder noise in terms of the ringing or the buzzing. So one way to try to combat that, at least to try to trick the brain into thinking the sound is outside rather than in, is to use something like a sound machine or a noise machine, or even just playing some background music. What it does is, again, it just gives a low stimulus for the brain to always focus on. And sometimes that can help to dampen the sound. For patients where tinnitus is just unrelenting and significantly impacting their quality of life, really, again, the treatment strategies are tailored towards trying to make it so that it's not quite as impactful. The mainstay is really something called cognitive behavioral therapy, CBT for short. The idea behind CBT is we're just trying to reassociate the person's perceived annoyance or impact of the tinnitus to something else so that they're not as impacted or hopefully not as bothered by the ringing or buzzing. The other thing that sometimes can be very helpful, and a lot of it, again, kind of depends on the hearing loss that's present, if or what type of hearing loss, is actually hearing aids. So patients that have particularly age-related changes in hearing, if they're starting to get a lot of the ringing or buzzing in the ear, sometimes using hearing aids to try to bring back, quote unquote, some of that hearing and also help to quiet some of the ringing or the buzzing that they hear. A little bit newer therapy in terms of how we approach tinnitus is something called sound training. So sound training, the idea behind it is, again, we're trying to teach the brain or try to reprogram the brain so that it doesn't produce its own stimulus and actually is more associated with the external environment. There's a newer procedure, or not necessarily a procedure, but newer device that was recently FDA approved probably about a year ago, where it uses what we call dual stimulation. So a sound stimulus through the headphones, as well as a stimulus or a stimulus through the tongue. So when you're actually listening to the sound, the device is playing a stimulus on the tongue. And by using those two sort of stimuli, studies have shown that that can also potentially help to dampen the stimulus that the brain is doing that produces the tinnitus. So again, those are kind of the options that we have for tinnitus and hearing loss. If patients Google tinnitus, or if you go online and kind of search for treatments for tinnitus, you're going to see a lot of things that pop up. in terms of potential management. I always tell patients we don't really have good data or good scientific backing to say that a lot of these tinnitus therapies are effective. That doesn't mean that I discourage patients from using it. So one of the common things that patients will try are things called lipoflavonoids, which are basically like a daily supplement. If you kind of look at the sort of data behind it, or the components of it, it's most commonly just like a multivitamin. There's also potentially drops that patients can use that can help with the ear ringing. And then I know some patients of mine will try acupuncture. It doesn't hurt to try it in the sense that I tell most patients none of them are very harmful. But if it's not really working after the first or second attempt, I wouldn't go spend more money on it, only because, again, there's not a lot of good data supporting it. So when we're talking about tinnitus and hearing loss, again, treating the hearing loss itself can sometimes help with the tinnitus. Really, a lot of it depends on the cause. And I like to highlight the importance of managing the hearing loss. When we talk about managing the hearing loss, hearing rehabilitation for patients with again, the most common type of hearing loss, which is age-related changes, is really with use of hearing aids. A lot of times the hearing aids can help to bring back some of that hearing while you're using it. And that can also quiet the tinnitus. Depending on the cause, again, the hearing test tells us if you do have something called conductive hearing loss, right, then there are certain medications and procedures that we can potentially do to also improve the hearing. And by improving the hearing, we can potentially help bring back, again, some of the sound that you're hearing, but also to sometimes quiet the hearing loss. Best example I have for you is, again, in kids, for instance, if there's fluid behind the ear that's not clearing, sometimes doing a procedure called an ear tube can help to, again, relieve that fluid and potentially bring that hearing back. The main reason why we want to treat hearing loss is that studies have shown that it can lead to higher risk for development of a bunch of different comorbidities, the biggest being earlier development of dementia and or cognitive decline. So a lot of times when we talk about dementia and or cognitive decline as it relates to hearing loss, when patients have a hearing loss and aren't utilizing aspects of their brain, that can again lead to a faster deterioration in terms of their ability to hear, ability to memorize, just their overall cognitive function. A lot of times with hearing loss, it leads to a lot of anxiety in patients, but also potentially to something called social isolation. So when you're not hearing your environment as well, patients tend to become more isolated to themselves. And that can, again, lead to more anxiety, more depression. And then the other big reason is really safety issues. So if you're not hearing the smoke alarm go off, or if you're not hearing sirens ringing, it can lead to situations where you're in a more dangerous environment and can't appropriately respond. So with tinnitus and hearing loss, a lot of times there are some red flags that I tell patients that you want to pay attention to. The biggest red flag that I tell everybody to pay attention to is if all of a sudden you develop ringing or buzzing in the ear and it's very sudden and very loud, and or if you notice a hearing loss. The reason why we want to know that is because when we talk about a sudden hearing loss, particularly a sudden nerve-related hearing loss, there are things that we can do to potentially try to bring some of that hearing back. The most common being a medication called steroids. The most common reason for sort of a sudden development in hearing loss is usually some type of virus or infection that causes inflammation to the nerve to the hearings. And by decreasing some of that inflammation, we can potentially facilitate recovery. The biggest sort of challenge with the steroids or with any treatment for sudden hearing loss is that time really matters. So if you develop the ringing all of a sudden and you wait 6 months to get seen or treated, the likelihood of us being able to bring anything back is very, very low. Versus if we see you within a couple of days and start therapy, then the chances are much higher. The other big red flag that I tell patients is if you're noticing that there's only one-sided tinnitus. So ideally, when we talk about hearing loss in general, the expectation is that things should be equal. So if there's only one-sided ringing or buzzing or one-sided hearing loss, then we always wonder, is there something else going on? Now, it doesn't necessarily mean it's dangerous, but a lot of times if there's one-sided hearing loss or ringing, it does warrant for further evaluation. So next, we'll kind of move on to ear pain, which is another common presenting complaint in not just ENT practices, but in general practices, ERs, etc. So the most common causes of ear pain, it really depends on pediatrics versus adults, but one common is just ear infections, and ear infections can involve both the either the middle ear and or the outer ear. Middle ear being sort of fluid behind the eardrum or inflammation behind the eardrum, versus outer ear being something like swimmer's ear, so clogging of the ear canal itself. Those are more commonly seen in kids than in adults, but again, can be a common cause across the board. The most common sort of complaint or most common cause of ear pain in adults actually typically doesn't have to do with the ear itself. It has to do with something called the temporal mandibular joint, or TMJ dysfunction, so the jawbone joint, and or the associated muscles around that joint. So in front of the ear canal, if you kind of put your finger in front of it and open and close your jaw, you'll feel that you have a little divot there. That's actually the hinge in which the jaw opens and closes. And inflammation or irritation in that joint and or the muscles that attach to that joint can also give you referred pain to the ear. Other common causes, cerumen. So if you have wax kind of sitting in the ear, you can also get referred pain from throat infections or dental issues. And then another thing that I also see in patients when they, if they're trying to clean their ears at home, for instance, and they use Q-tips, sometimes ear trauma can also lead to pain and dysfunction. With ear pain, a lot of the management, again, is targeted towards the cause, but there are some things that you can try at home if you wake up in the morning with some discomfort. The most common things that tend to help, sometimes using some warm compresses or heat to that ear or around the ear can help to relax some of the muscles, relax the discomfort that you feel in the ear canal itself. Massaging the outer ear, so the area around the front of the ear as well as the back of the ear can also help. A lot of times over-the-counter pain medications, so things like Advil or ibuprofen, Tylenol can also help in terms of decreasing some of the pain and discomfort. A lot of those targeted therapies, particularly with ibuprofen, just helps to decrease the inflammation, particularly in the ear canal and or the jawbone joint, and that can relieve some of the pain. I'll also have patients sometimes use some baby oil or mineral oil in the ear. It just helps to moisturize the ear canal. That can help to sometimes soothe the discomfort. It can also help to prevent water from getting trapped or building up in the ear. That again can lead to pain or discomfort. Otherwise, if the pain is kind of persistent or if it's not getting better, a lot of times, sometimes medications need to be used. For wax and things like that, the over-the-counter Debrox or hydrogen peroxide can help. I always tell patients avoid using water irrigation in the ear, because when water gets trapped in the ear, it just breeds an area for more likely to develop an ear infection. Other times, antibiotic or steroid drops, sometimes oral antibiotics are needed as well. One thing that I also tell patients, if you develop the ear pain or pressure with conjunction with like a cold with stuffiness, congestion, and or with like flying, so changes in elevation, sometimes using nasal sprays like Flonase or Azelastine, and we'll get into a little bit more with the congestion and stuffiness, but sometimes using those nasal sprays can also help to decongest the nose, which ultimately can help to decongest the ears. The red flag symptoms that you really want to look at for when we talk about ear pain, it's really if the pain is just unrelenting, severe, constant, if it seems like it was getting better and then all of a sudden got worse, or if it just steadily is getting worse. Those are all things that it's worth it to come in and see somebody, just so that we can get a better idea of what's going on in the ear. If you notice associated changes in hearing with it as well as ear drainage. So if there's bleeding or pus kind of coming out of the ear, those are all things that, again, can indicate something more sinister going on. So that's sort of ear pain in a nutshell. We'll move on into talking about nasal congestion and postnasal drip and runny nose. So nasal congestion and or runny nose is a very, very common complaint that presents to ENT practices. And it can be the result of many things, in the sense that when we talk about stuffiness in the nose, it can be a combination of swelling or inflammation of the nasal lining. It can be sinus issues. It can be structural issues that all just lead to the inability to sort of move air through the nose well as overproduction of the mucus. When we talk about runny nose, it can also be the source of the stuffy nose. At the same time, patients who just constantly feel like they're using a tissue to wipe their nose 24/7, or feel like mucus is always dripping into the throat. Sometimes that can be associated with just overactivity of production of mucus in the nose, and there's different managements or treatments to try to help alleviate that. Again, the most common environmental causes of nasal congestion, things like allergies, dust, pollen, irritants. So think about certain strong irritants, perfume, smoke, etc. All those can lead to, again, irritation of the lining of the nose, and ultimately swelling and stuffiness. Common, again, cold, flu. It's not uncommon to develop stuffy nose congestion. And a lot of times when the nose isn't breathing well, that can also result in backup in the sinuses. And when the sinuses are stuffed and not draining well, again, that can also lead to more congestion, more of the runniness. And then I kind of alluded to it briefly. I don't have the pictures to show, but when we talk about the congestion and stuffiness in general, I usually tell patients about the interplay between inflammation and structure. So when we talk about inflammation, again, that has to do with the lining of the nose sort of swelling and or enlarging, and then that narrows the nasal passage. At the same time, when we talk about structure is really kind of how much space do you have available to begin with. And structure can be impacted by common things like a deviated septum. So the septum is what divides the left and right nostril from each other. If that's not straight, right, or if it's off to one side, that can cause the nose to feel a lot tighter and be more predisposed to inability to move air. At the same time, if the turbinates are enlarged or swollen and taking up space, that can also lead to issues or problems, as well as so the narrowest portion of the nose is something called the internal nasal valve, and it's made up of partly by one of the cartilages on the outside of the nose. And if that sits in a much narrower position and or tends to want to collapse when we breathe in, that can also lead to a lot of the stuffiness. When we talk about chronic sinus disease, I usually tell patients the sinuses are the easiest way to think about the sinuses are like plumbing. So all the sinus cavities want to drain into the nose. So if anywhere along the drainage pathway, there's something blocking the ability for the sinuses to drain, everything else upstream of it, so think of it within the cavity itself, can get backed up, and that can lead to fluid, inflammation, and a lot of the symptoms of stuffiness, pressure. So a lot of times the goals towards treating nasal congestion and stuffiness is really medical management, and medical management with both sort of non-medicated and medicated rinses and sprays. The number one thing I tell patients when we talk about medical management for congestion, stuffiness, runny nose is you just have to be very consistent during the period where you're having the symptoms. So one of the single best things that patients can do to try to help open up their nose and help to kind of clear out the nose and the sinuses is to do something called a nasal saline rinse. So if you've ever seen things like neti pots or Neomed sinus rinses, they're basically high volume irrigation for the nose. It's kind of like giving a bath to the nose. And by using that on a daily basis or even twice daily basis, it just helps to clean out all the gunk and the mucus within the nostrils, within the sinuses, and keeps a nice clean surface that can really help to keep the nose open. Other things you can do include humidification, steam baths, and just help to kind of open up the nose, keep things running a little bit more smoothly. Avoiding environmental triggers. So if you know you have really, really bad allergies and whatnot, avoiding sort of things that will create more inflammation can also help. And then you start to bridge into things like medicated nasal sprays. So again, the most commonly used one is something called Flonase, and or their class of medication, which can include like Nasacort, Rhinocort, and then another type of medication called Azalastin, which is an antihistamine nasal spray, so kind of like Claritin or Zyrtec for the nose. And they work by just decreasing the inflammatory response of the nose, so decreasing the swelling. And again, if you're consistent with it, it can really help to open up the nose. For patients who get really runny noses, there's a prescription medication that I'll actually try with patients. It's called Atrovent. It works by basically decreasing the activity of the nerves in the nose from producing mucus, and that can also be very effective in helping limit the postnasal drip and or runniness. At the end of the day, if symptoms just kind of persist or are not getting better, and or sinuses are again super infected or impacted, sometimes antibiotics and or steroids can also help. But again, the number one thing, if you remember anything from kind of the conversation, is whatever you do choose to attack the nose with, you just have to be very consistent with it, because we don't have a cure for inflammation. So a lot of the therapies are targeted towards trying to keep that inflammation at bay. Now, in terms of breathing through the nose in general, there are non-invasive ways to try to open up the nose too. Now, most of the time this is done when patients are sleeping at night. And what we do is, again, I kind of mentioned it before, but the narrowest portion of the nose is an area called the nasal valve, which is right in the front of the nose. And what we do with these devices, so something called breathe right strips, if you've seen like little stickers that people wear over their nose, and or something called an intranasal cone, which is on the left side. These little things can actually go into the nostril and kind of pop that cartilage out. Again, just to try to help open up the nasal passage. I find for patients, particularly that are impacted at night, so if you find like every time you lay down to sleep at night, the nose just gets stuffy, a lot of times these can be very effective in trying to open it up and help optimize your ability to breathe through the nose. When do we really seek medical attention for congestion and stuffiness? It's really if it's just persistent. So if it's something where it's been impacting you all your life kind of situation, or if you've noticed it's been going on for months and just doesn't seem to be improving, that's a good time to potentially see an ENT just to get a better idea of what the structure is in the nose and kind of what's impacting it. In the acute period, if you're getting a lot of yellow greenish drainage, a lot of facial pressure, a lot of high fevers and or swelling around the eyes or the pain or the nose itself, that's also an indication that it could be something more than just everyday allergies. It could be something like a bacterial sinus infection. And a lot of times if you're having sinus symptoms, those pressure, the mucus over 10 days, that's also a hard indication to actually see an ENT for further treatment or management. Ultimately for the nose and the sinus, and we won't dive too much into it, but ultimately surgery is sometimes necessary because there's only so much that you can do in terms of handling inflammation of the nose with medications. If the structure is predisposing you to congestion and stuffiness. And again, usually I try to optimize the medical aspect before we pursue any invasive procedures. And I would say almost 90 to 95% of the patients, of my patients, if they're consistent with the medical management, that's usually enough, where not a lot of them actually have to go forward with procedures. So the next thing we'll talk about is sort of the triad between cough, sore throat, and throat clearing, which is also a very common triad that comes together. When we talk about cough, sore throat, and sort of that need to clear your throat, the common causes usually are in the acute phase. If it just started, a lot of times a common cold or flu can give you those sensation or that need. But a lot of times when we start to worry are more when those symptoms persist for 2, 3, 4 weeks out from the initial cold. And again, the sources usually are potentially mucus from the nose, so postnasal drip, mucus dripping into the throat and irritating the voice box, causing that sensation. In adults, actually, I would say 90 to 95% of patients that have that persistent symptoms, so if they come in describing the cough and feeling of throat clearing for 3-4 months or more, the most common cause is actually typically acid reflux. And it doesn't have to be reflux in the sense of where we talk about patients feeling like they're having burning in the stomach or stuff coming up from the throat. What reflux, it can be something called silent reflux, where just a little acidity over time chronically irritates the throat, and that can give you that sensation where you're coughing and clearing. Another big factor, particularly if you're getting the symptoms, if you're waking up at night, kind of clearing your throat or feeling sore, is actually dry mouth or dry throat, and usually as a result of mouth breathing. And again, those can lead to some of those symptoms. When we talk about management for the symptoms, really I start with a lot of conservative stuff first. Some things you can do at home. A lot of times using like warm water or drinking warm water and or tea and mixing it with honey or ginger can be very soothing for the back of the throat. That can help with any soreness. That can also help with sometimes the mucus sensation because it acts as a little barrier for any irritant hitting the voice box. You want to make sure you have good hydration, good humidification. If the throat is really painful, then again, the over-the-counter pain medications can be helpful. Sometimes doing once daily or twice daily warm salt water gargles can also keep the throat nice and clean. It helps to basically get into the crevices of tonsils, the back of the throat, and kind of clean it out, and that can help soothe some of the discomfort. Again, with reflux being one of the main irritants in the back of the throat, diet is a big factor in trying to manage that. And with the diet, again, a lot of times it's focusing on limiting things that increase acidity in the back of the throat or increasing the risk for reflux. That can be things like spicy foods, greasy, oily foods, citrus-based foods, tomato-based foods, coffee and tea, or things with caffeine in a sense. All those things can potentially worsen symptoms, and sometimes just by limiting those irritants, a lot of times the symptoms can also improve. If things kind of persist, I usually have patients try using things like reflux medications, because a lot of times the irritant, by limiting the acidity, that can also help in terms of resolving the symptoms. But I tell patients it can be a long process. So sometimes those symptoms can take up to anywhere from 3 to 6 months before really clearing. And the biggest thing is just being consistent. Even with the reflux medication, just once a day, every day for even like 2 or 3 months, might help to resolve it. I also will have patients potentially try nasal sprays, like we talked about with the congestion. One of the big reasons is, again, if mouth breathing or dryness, or if it's impacting when you're sleeping, by basically keeping the nose open, sometimes that can really help to keep the mouth closed at night and can help to relieve some of the symptoms. For when do you seek medical attention? Again, a lot of times it's just kind of worst case scenario. If you feel like you're having unrelenting pain, worst sore throat you've ever had kind of situation. If you can't tolerate anything to eat or drink, and those are all signs where, again, what's going on in the back of the throat might be a lot more aggressive or a lot more dangerous, or an infection in a sense. Symptoms are lasting greater than 4 to 6 weeks, and or if you also notice a lot of voice changes that are lasting for more than a week, up to 2 weeks, 3 weeks at a time, without improvement, those are all things that warrant just a closer look to make sure there's nothing physically going on in the throat or the voice box that causes it. So the last topic we'll kind of talk about is really snoring and sleep issues, which again is very common in ENT practices. So snoring is basically just a sound that happens because of some type of obstruction in the airway. So some type of blockage in the airway. And that can be at the level of the nose, that can be at the level of the back of the throat, the tongue, the voice box. But something in the throat or in the nose is causing the air that's coming in to become turbulent because it's being obstructed to some extent. And then that causes vibrations of the soft palate in the back of the throat that produces the noise. Now, snoring in itself is not dangerous, but there are things with snoring that we look out for. If snoring is very mild, there are some conservative things you can try to see if it helps in terms of improving the snoring. Again, one big thing is kind of improving nasal breathing and what we call closed mouth breathing. The idea behind that is that when we're breathing all through the nose, the air that comes in is a lot more calm than if we're breathing with our mouth open. The other thing that tends to happen when the mouth is closed, the tongue actually sits in a further forward position, and the airway starts out wider and more open because the jaw is also more forward. When the mouth is open and you're breathing, a lot of times the tongue tends to flop back, and again, that can lead to a lot of the obstruction. Sleeping on your side can help. Usually snoring is worse when you're lying straight on your back. Sleeping with your head elevated can also help. And avoiding sedatives, so things that kind of make you more drowsy or more relaxed. So think of like sleeping pills, think about alcohol, muscle relaxants. All those just kind of predispose the airway to kind of narrow and want to close up. The other thing that tends to help is weight loss. So the more weight that you have, particularly in the neck or the throat, just tends to cause the airway to start in a more tighter position. And that can a lot of times lead to more snoring and more obstruction. Now, the biggest thing that we worry about with snoring, and again, I kind of alluded, snoring itself isn't dangerous, but snoring is kind of on the pathway towards obstruction. And the biggest thing that we worry about with snoring is if you have underlying what we call obstructive sleep apnea. So some of the symptoms to look out for on top of the snoring is if you're waking up always feeling tired, always feeling fatigued, if you sleep like 8-9 hours and you wake up and you're still groggy tired, if you need naps throughout the day, if it's hard to focus during the day, those are all signs that can point towards, again, lack of quality of sleep and potentially significant obstruction. If anyone has told you they think you stop breathing at night, or if you wake yourself up in the middle of the night, those are all things that, again, you want to know about. So obstructive sleep apnea is basically just when the airway collapses enough where the person either stops breathing or they decrease their breathing enough where their oxygen levels drop. And the reason why we really care about sleep apnea, again, in the population in North America, there's probably about 50 to 30% of males that are impacted and 10 to 15% of females. But it has an association with a lot of other bad things. So bad things being increased risk for high blood pressure, diabetes, stroke, heart attack. And again, a lot of it just kind of depends on the severity of sleep apnea. But knowing about it really helps us figure out, again, treatment and potentially trying to limit the impact in developing other comorbidities. In the other thing I like to talk about with sleep apnea, and I harp on when it comes to the Asian population, is that Asians actually tend to be at much higher risk for developing obstructive sleep apnea. There was actually a study out in Taiwan that noted the prevalence or the likelihood of sleep apnea in their population was as high as even 70%. And a lot of times for Asians or Chinese individuals with obstructive sleep apnea, it doesn't have to do with weight per se. It just has to do with your facial structure. So a lot of times the Asian counterparts, when they talk about the severity of sleep apnea, tended to be much worse and to happen much earlier in age than their Caucasian counterparts. The very first step when we talk about, and again, I won't dive too much into treatment and management, but it's just kind of so you guys are aware. When we talk about sleep apnea in general, if there's any concern for it, the very first step is just to get a sleep study. So I like to highlight, I got a sleep study about 10, 12 years now ago. And I was diagnosed with sleep apnea. Since then, I've been on management for it. But it's something that, again, you don't expect when you're a lot younger to have it, because the risk kind of increases with age. But when we talk about the Asian population and kind of the way our facial structure is, it really predisposes to potentially having that. So if you notice any symptoms of fatigue, tiredness, etc., being diagnosed with sleep apnea and trying to manage that in the long run can be very helpful in terms of preventing other bad things in terms of health development over time. So that's really what I have for you today. Again, thank you guys for your attention and your time.